Hello everyone, this is Dr. Krishan. Today in our video lecture series for the ENT PGs, we are coming to the topic conservative laryngeal surgeries. Basically, we will do more of the video series like this on different hot topics which are being asked in the postgraduate exams and also useful for those who are pursuing their post-graduation in their daily day-to-day duties and in emergency or in routine OTs and all. So, myself, Dr. Krishan, I am ENT surgeon based in Delhi, and I am co-convener in Indian Medical Association, and I am the author to 55 medical books. We have another ENT surgeons from Mumbai, Dr. Shivani. She will give her introduction, then we will proceed with the lecture. So, Dr. Shivani.
Hello, myself Dr. Shivani. I'm practicing in Mumbai. I have already covered, me and Krishan have already discussed topics earlier also. Today, also, we are going to cover very important conservative laryngeal surgeries. Krishan?
Okay. So, conservative laryngeal surgeries. The main, what are the surgical principle? Any surgeries is governed by any by surgical principle. So here the main surgical principle is oncologically safe excision of the tumor. Means we should not be left with any tumor. There should be adequate excision along with taking the margins. Preservation of the essential functions of larynx. This is very important in any laryngeal surgeries. That the before doing the surgery, we should recognize which function of the larynx is most important for our concerning patient. Then we should try to preserve that function. So here we have the essential functions of larynx are phonation, nasal respiration, protection of airway.
Correct.
Yeah. It is based on embryological compartment of larynx. So the principle governing the conservative laryngeal surgery is based on embryological compartmentalization of the larynx. Conservative laryngeal surgery may be open partial laryngectomy or transoral endoscopic resection using the CO2 laser.
Okay.
So, before proceeding to the surgery, we will discuss about the cricoarytenoid unit. So, it is a basic functional unit of the larynx. Should be left post resection of tumor in cases of conservative surgeries. It maintains the essential function of larynx. What are they? They are phonation, nasal respiration, and airway protection. It consists of intact cricoid ring as well as one mobile arytenoid cartilage. Sensory innervation of remnant larynx should be preserved by the bilateral recurrent laryngeal nerves and as well as the main trunk and posterior descending branch of the internal division of superior laryngeal nerve. So this is showing the this functioning arytenoid. This is intact quadring, intact cricoid ring. This shows the minimal functional remnant for a successful partial laryngectomy. So open partial laryngectomy, various procedures can be done based on it, based on the side of the cancer. So this is the broad term. Open partial laryngectomy is the broad term. We have different types of surgery based on the site of the lesion or site of the cancer. So in glottic CA, we do cordectomy through laryngofacial. Then there is vertical partial laryngectomy, and then supracricoid partial laryngectomy with cricohado epiglotticopexy. Basically, in latter part of the lecture, we will see there is a stage-wise division also. So early supraglottic cancer, in early supraglottic cancer, we do supraglottic partial laryngectomy or extended supraglottic partial laryngectomy. There is also a term like vertical partial laryngectomy and horizontal partial laryngectomy. Then when the lesion is involved glottic as well as supraglottic part, we have supracricoid partial laryngectomy with cricohadopexy. Then there is 3/4 laryngectomy. So, patient selection. Regarding the patient selection,
Before that, I would like to add one thing that whenever it comes to larynx, you should be knowing the following the topics which you are supposed to know. I mean, 10 The first thing is that you must be knowing the functions of larynx. Second, the subsets of larynx, that is supraglottis, glottis, and subglottis. And the third is carcinoma of larynx, most common site, and how the patient presents to you, so that you can do the patient selection. Okay. So before doing any patient selection, you should be knowing the following functions: the subsites of the larynx, and what are the sites where how the patient present to the OPD, and what are the complaints of the patient while they present to the OPD.
Along with that, the one thing that Dr. Shivani has stressed upon, the supraglottic, how the supraglottic CA patient will present, how that the glottic CA, just supraglottic CA patient present with difficulty in swallowing, glottic present with glottic present with
Shortness of voice.
change in voice, and the
Yes.
subglottis present with difficulty in breathing or like that. So moreover, there are also questions are asked in viva exams, in PG exams, like that ki if patient is presenting with pain in ear, so which will be the site of the lesion in the in this CA larynx. So you should be pain will first come, questions are framed like that: pain will first come in the CA larynx or CA oral cavity. So questions are framed like that. For answering that, you should be thorough with the nerve supply, sensory supply of the
Yes.
concerned part. So now we will discuss the patient selection. There is high risk of post-operative aspiration and pneumonia, which is exacerbated by the poor wound healing, local infections, and fistula formation. Therefore, stringent patient selection is mandatory for successful outcome. Factors which are associated with poor outcome, जैसे आप देखोगे जब भी CA larynx का पेशेंट हम प्लान करते हैं तो हम रेस्पिरेटरी कॉल, पल्मोनरी फंक्शन टेस्ट, ये सब कराते हैं. बिकॉज व्हाई दूज आर इंपॉर्टेंट? क्योंकि एक पल्मोनरी रिजर्व होना चाहिए पेशेंट का, तभी हम उसको केस के लिए लेंगे. सो हियर वी हैव डिस्कस दैट कि पुअर पल्मोनरी रिजर्व को हम मतलब कि इनमें मतलब कि कोई फायदा नहीं होगा, वो क्वालिटी ऑफ लाइफ भी इफेक्ट हो जाएगी. सो क्या क्या हम देखेंगे? सीओपीडी, अस्थमा और रिस्ट्रिक्टिव लंग डिजीज. रिस्ट्रिक्टिव लंग डिजीज से हमारा क्या मतलब है? जैसे सिलिकोसिस, जो भी ऑक्यूपेशनल लंग डिजीज होते हैं, दीज आर.
Here we need to know. Yes, Dr. Krishan.
Yes, you can continue.
One thing you should be knowing that हम patient का larynx निकालने वाले हैं इसके बाद, और some part of larynx we are going to remove. So for the lungs are going to get exposed to the outer environment directly. So the first priority to select the patient for the laryngectomy any type, first is that pulmonary function test should be normal. और उसके लिए PFT and all test हम करवाते हैं patient का सबसे पहले. And the second thing is patient should stop smoking. We have seen almost, Dr. Krishan would have also seen so many of the patients which used to smoke even after doing this much big surgery. So the first part is the patient selection, and the counseling should go hand in hand about the patient. Operation होने के बाद you need to follow this protocol. Okay.
Quitting smoking is important for both thing ki post-op healing will be better. Also, radiotherapy, success of radiotherapy decreases if the patient smokes in post-op period also. So these things are mentioned in any standard book, Scott Brown or any Stelmaran. So this is important also. So patient non-compliance. Then second, we are discussing chronic microvascular or immunological disease that impair wound healing, diabetes, transplantation patients. So these are immunocompromised patients. So you are doing a major surgery, total laryngectomy or any conservative laryngeal surgeries are also a major surgery. So the patient non-compliance or comorbidity or any other cancer. So laryngophysios. So now we will take one surgery one by one. All the surgeries we'll discuss. So laryngophysios with cordectomy. So many people ask which book they should follow for studying larynx. PGs ask. So two books are good books. Earlier there was only one book, but now people say there is Sultan Pradhan, as well as there is a textbook of laryngology by Laryngology and Phonosurgery, textbook of phonosurgery by Nupur
No,
ma'am.
good neighbor,
So
ma'am.
both are good. Actually, what the problem is with Sultan Pradhan sir's book, it is not available. If you are getting PDF, then you can get photocopy. Moreover, the Sultan Pradhan sir book, I think the most of the books which are available with our seniors, which were available with even our with our seniors, they were black and white. So better go with Nupur ma'am's book, that is colored. That is, I think, available in 2000 rupees. PDF is not available. I think you have to buy the book only, and that book is wonderful. So coming to the laryngophysis with cordectomy. So this is simplest and oldest open surgical procedures for early glottic cancers. What are the indications? So in any surgery, you have to first thorough with the indication of that surgery, contraindication of that surgery, complications of that surgery, and the procedures, means how we perform the surgery. These are important. So in ENT, read any surgery like that. Indications. So mid cord lesion, if you have mid cord lesion not reaching anterior commission, no impairment of cord mobility. This is important. So you should highlight on these things. Okay? If there is no impairment of cord mobility, we'll do cordectomy. So coming to the procedures, so we give general anesthesia through tracheostomy. Then midline vertical thyrotomy incision given larynx entered through cricothyroid membrane. Then soft tissue removed deep to ipsilateral thyroid cartilage. So what margins we take? It is important, and you should remember this. Anterior 2 to 3 millimeter behind anterior commissure. Posteriorly we take till vocal process of arytenoid. Then superiorly just above false vocal cord. Then inferiorly lower border of thyroid cartilage. This is. And then thyroid cartilage and perichondrium are approximated. Mucosal defect healed by granulation. Dense fibrous pseudocord forms postoperatively. Tracheostomy is decannulated within a week and allowed to close. 84 to 98% control rates. Quality of voice is inferior to endoscopic laser cordectomy. That's why these days laser surgery are preferred. Well tolerated in elderly. So this is a photograph that is taken from Sultan Pradhan sir book. Yeah. So this is laryngophysial cartilage cut to gain entry. So midline vertical thyrotomy incision given in the cricothyroid membrane. After this, we reach the larynx. Then this extent of resection. So this is already discussed. Just see. Anteriorly 2 to 3 millimeter behind anterior commissure. So this 2 to 3 millimeter behind anterior commissure. Then posteriorly we were taking till arytenoid. Yeah, posteriorly till vocal process of arytenoid. Then superiorly just above the false cord. Superiorly just above the false cord. Inferiorly below the thyroid cut. This is. One thing is very important about the Sultan Pradhan sir book is, sir, photographs are wonderful for exams. If you want to draw photographs for the exam, then this is wonderful book. Like that. All the pencil diagram are wonderful. You can draw in exam. So for drawing any diagrams in phonosurgeries or larynx, you should refer the this Sultan Pradhan sir book. What we used to do during our post graduation, all the diagrams in any larynx case which we used to operate, we were instructed by our consultant to draw the diagrams in all the anteroposterior, transverse, longitudinal section in the OT notes of that patient. So we used to draw, and this was very good practice suggested by one of our consultants. And actually, if you will see the OT notes of most of the reputed hospitals, they in few departments, especially in pediatric surgery, I have seen few consultants don't write a single word in the OT notes. They represent everything with the diagram. I have seen in Sir Gangaram Hospital, many pediatric surgery consultants, they don't write anything in the OT notes. They just draw diagrams. So this is the good practice you can also incorporate in your institute. So after this we'll discuss vertical partial laryngectomy. This is also called vertical hemilaryngectomy. This is hemilaryngectomy. So various procedures depend on the location of the tumors. So various procedures are discussed depending on the location of the tumor. So hemilaryngectomy, frontal laryngectomy, extended hemilaryngectomy. So hemilaryngectomy, cord lesions without involvement of anterior commissure. So when there is a cord lesions without involvement of the anterior commissure or the arytenoid, so this is hemilaryngectomy as it has been shown in this photo. What we do in frontal, when anterior commissure lesion, then we do vertical partial laryngectomy, VPL. Then this is frontal. Frontolateral means cord lesion, cord lesion is extending across the anterior commissure. Then this is extended hemilaryngectomy, cord lesion involving the arytenoid also. So these are 4 types of vertical partial laryngectomy. So what are the indications of vertical partial laryngectomy? We'll discuss. So involvement of anterior commissure, impaired mobility of vocal cord. When there is impaired mobility of vocal cord, when supraglottic extension of disease less than 10 mm anteriorly and less than 5 mm posteriorly. Regarding this, now you should know one thing. What is the role of anterior chink? What is the role of posterior chink? So posterior chink is for airway, mainly for airway. Anterior chink is mainly for voice. So you should consider this while you are discussing this vertical partial laryngectomy or like that. So subglottic extension of disease is less than 10 mm anteriorly or less than 5 mm posteriorly. And less than 5 mm posteriorly. Inadequate exposure on microlaryngoscopy, salvage of post-RT recurrence when the patient has been given post-RT and there is recurrence. Select T3 lesions where both the vocal cords are fixed but both arytenoids are mobile. So we encounter this kind of many cases when the vocal cord are fixed but arytenoids are mobile. What's the limitations? So subglottic extension more than 10 mm anteriorly and more than 5 mm posteriorly, then this can't be done. Just reverse the indication. Paraglottic disease, involvement of more than 1/3 of contralateral vocal cord, fixity. When there is fixity of arytenoid, you can't do vertical partial laryngectomy. Any input from you, Dr. Shivani? Any kind of question you can recall that were being asked during your exams, PG exams?
Yeah, whenever we are going for Viva, you should firstly keep in mind that we are not going to do total laryngectomy at all, because many of the surgeries today are conservative surgeries. That is why whatever we are learning is conservative surgeries. So we would like to save the voice of the patient. Whenever you are going, whenever you teaching staging of the cancer. There is cord, and whenever there is a cord fixation, it is a difficulty for the surgeon to save the voice, unless if there is a cricoarytenoid unit is present. Otherwise, in order to have of a patient after the surgery, we mostly go for the conservative surgery. So whenever you are asked about the type of a treatment going to do for a patient of CA larynx or CA supraglottis or subglottis, go for the conservative surgeries first. Okay, and this should be the answer.
Initially, you will also remember that in stage 1 we do radiotherapy. So this is one example of that thing.
Okay.
So procedures. Now we'll discuss the procedures of this vertical partial laryngectomy. So full thickness and block segment of the involved glottis with overlying thyroid cartilage and intervening paraglottic tissues. Then margins of mucosal resections. Upper margin we take false vocal cord, lower margin evoke required. GA we give through tracheostomy, horizontal skin incision at the level of thyroid cartilage between two sternocleidomastoid muscle. Two vertical cartilage cuts placed depending on the side of the lesion enter in larynx via the cricothyroid membrane. Then both superior laryngeal nerve preserved, epiglottis preserved. Reconstruction is done by reattachment of the contralateral true vocal cord to adjoining thyroid cartilage. Mucosal defects need not be reconstructed. In classical vertical partial laryngectomy, heals via the granulation from pseudocords. To reconstruct resection arytenoids, we use muscle, tendon, fat, cartilage, or epiglottis. As reconstructing posterior bulk is important. Why important? Due to the airway. So this is a photographic representation. So figure 6A to D, cartilage cuts for different types of this VPL we have already learned. Conventional
These are
VPL.
very diagrams actually. Everyone should take a note of these diagrams. If you draw these diagrams, you'll definitely going to get a good marks.
Yeah, practice diagrams from the Sultan Pradhan sir book, or I have included most of the diagrams in this PPT. Just practice diagram. See diagram first, then read text. This is very important in any kind of surgeries. So conventional, this is VPL, conventional VPL, this is frontal, this is frontolateral, this is extended hemilaryngectomy. Okay. So what are the complications? Complications is laryngeal stenosis and delayed decannulations. Then there is aspiration, that is poor voice quality. Even with all the prosthesis and all, we see the quality of voice is robotics type here. Results देखिए. In T1, what is the percentage of control rate? So in T1 more than 90%, T2 more than 82%. This is and T3 64%. So coming to the supracricoid laryngectomy with cricohadoepiglottopexy. So it deals essentially with glottosupraglottic tumors and involves removal of entire thyroid cartilage and the entire length of both true cords along with the paraglottic space. So basically what we are doing we are doing this surgery in glottosupraglottic tumor. Glotto means glottis is involved, supraglottis is involved. And removal of entire thyroid cartilage and the entire length of both true cords along with the paraglottic space. It involves removal of both false cord and also the infrahyoid and when necessary, one arytenoid cartilage. Indications. So T1B with involvement more than half true vocal cord on either sides. T2A with extension to false vocal cord and base of the epiglottis. T2B cord mobility impaired, and T3 fixed vocal cord with freely mobile arytenoids. So what are the indications of this supracricoid laryngectomy with cricohadoepexy? So more than 1/3 of the contralateral cord involved, glottosupraglottic spread, impaired cord mobility, and the cord fixed and arytenoids mobile.
See here, every time you have to see for the mobile arytenoid because this is a basic unit we have to save in every surgery. So keep a note of this.
So what is the limitation? Fixity of arytenoid, then we can't do. Subglottic spread, supraglottic extension beyond false vocal cord, then prior tracheostomy if there is respiratory impairment due to any disease. So procedures, how we do? We are discussing the procedure of supracricoid laryngectomy with cricohadoepexy, SCPL. So GA given through orotracheal tube, subplatysmal apron incision. So questions exam ki apron incision is given in which surgery? They ask. This is a very basic question, but they ask. Subplatysmal apron incision used for the approach entry into the larynx is via the transepiglottic incision. Therefore essentially is that pre-epiglottic space should be free of disease. FVC, ventricles, and PVC completely resected out. Cricoid hyoid, hyoid epiglottis, bilateral superior laryngeal nerves preserved. Reconstruction done by cricohadoepexy and tracheostomy through separate incision. So what are the complications? Pneumonia due to aspiration, dehiscence of the cricohadoepexy, cricohadoepiglotticopexy, laryngeal stenosis. Results is survival rate is 68 to 84% and recurrence is 0 to 16%. Any input, Dr. Shivani, from your side?
Hey, you go ahead.
Yeah, coming to the procedures for supraglottic cancer, most common tumor of larynx is in India. This is also as in Viga. Marginal zone region lesions most frequent, present late, rich in lymphatics, have cervical nodes mets at presentation, spread preferentially in downward direction, need horizontal resections. Coming to the horizontal partial laryngectomy includes what it includes. So horizontal supraglottic partial laryngectomy where resection include the false cord, the epiglottis, the pre-epiglottic space, the upper third of the thyroid cartilage. The hyoid is included in the resections when the pre-epiglottic space is grossly infiltrated. Extended supraglottic partial laryngectomy. Forward horizontal supraglottic laryngectomy is extended to involve resections of the pyriform fossa vallicula. When these are involved, then we do extended supraglottic. So they can ask you when we'll do horizontal supraglottic partial laryngectomy, when extended. So extended will be done when pyriform fossa vallicula, base of the lung, or ipsilateral arytenoid is involved. So just see this anatomy. Classical supraglottic laryngectomy inclusions when the dotted line shows the structure is there. So this is higher pre-epiglottic space thyroid cartilage. So we were discussing supraglottic this supraglottic laryngectomy. What are the indications? So carcinoma of the infrahyoid epiglottis with involvement of pre-epiglottic space with mobile cords, supraglottic cancers with large neck secondaries N2 N3, supraglottic lesions in young adult. Radiotherapy itself carcinogenic in young. This should be important. Why this is important? Because when you will give the thyroid case presentation, they will ask about this fact. How you will know that the person is at risk. Then you will say ki radiation exposure. So then there comes one more thing ki what are the other causes, what are the other causes of radiation exposure which is not so common in present time. Then you say that ki in acne these all earlier they used to give radiation, this question, and even radiotherapy itself is carcinogen in young, so that's why it is not preferred, and they ask this question in thyroid case presentation. Especially this type of question is also asked from general surgery people also in their DNB exam. So contraindications in their thyroid case presentation. Contraindication. So what is the contraindication? Impaired cord mobility, poor pulmonary reserve, involvement of thyroid cartilage, involvement of piriform sinus apex, involvement of interarytenoid or post-prequire region, extensive base of tongue involvement, loss of vasculature. So this is ideal indication for supraglottic laryngectomy, supraglottic endolaryngeal disease with mobile vocal cords. In this extended supraglottic laryngectomy to include resections of ipsilateral arytenoid. Here arytenoid is also involved. The procedure can also be extended to include the portions of the base of the tongue or piriform. So coming to the procedures, preliminary tracheostomy may be performed. Perichondrium incision given along the upper border of thyroid cartilage separated from the cartilage and preserved. Incision of the thyroid cartilage should spare anterior commissure. Hyoid periosteum elevated, and bone may or may not be preserved fully depending upon the extent of the involvement of the pre-epiglottic space. Contralateral side hyoid anterior to the lesser cornea preserved. Preserve superior laryngeal nerve sensation, prevent aspiration. So why this superior laryngeal nerve is preserved? This is important. Pre-epiglottic space resected, anterior to the larynx, transvallicular, epiglottis pulled down with Alice forceps, aryepiglottic folds divided anterior to arytenoids. Inferior extensions of resection is up to the level of false vocal cord. True vocal cords are preserved. So classical supraglottic laryngectomy. This is the diagrammatic representation. Cartilage cuts the body. This is supraglottic laryngectomy. Cartilage cuts preserving the hyoid bone. So reconstruction following excision of the tumor is very important. Cricopharyngeal myotomy done to allow post-op surgery. Regarding the reconstruction, I would suggest if you are going for your fellowship exam, your fellowship interview at the KKR ENT hospital, they will sure if the KKR sir will be in interview, most probably he will be, and he will ask how you reconstruct in conservative surgery of larynx. And one more question he commonly asks, that key how you what you do for the voice preservation. So he asked these two questions very commonly. So cricopharyngeal myotomy done to allow the post-op swelling, closure of defect, suturing cuts edges of piriform fossa to oropharyngeal mucosa. Medially, closure is obtained by the approximating remaining part of the thyroid cartilage to base of the tongue, and if preserved with iron, preserved thyroid perichondrium now sutured to base of tongue musculature as a second layer of the closure. So coming to the extended supraglottic laryngectomy, extended means resections of involved arytenoid or lateral wall of the piriform fossa or vallecula or base of the tongue. Arytenoid resections can lead to aspiration and significantly poor quality of voice prevented by medialization ipsilateral cord remnant anchoring it to superior border of the cricoid cartilage. So arytenoid resection you can lead to aspiration and significant base of tongue or vallecular resections when tumors involve lingual surface of the epiglottis, vallecular and adjacent portion of the base of tongue. The entry in the larynx is made via the uninvolved ventricle inferiorly. One half of the base of the tongue is preserved. ਫਿਰ resections of the lateral wall of the piriform fossa along with the involved portion of the lateral and posterior pharyngeal wall is compatible with the extended supraglottic laryngectomy. Resultant defect is repaired by myocutaneous flap. So what are the, so we are discussing extended supraglottic laryngectomy. Complications, aspiration and pharyngocutaneous fistula, because we are touching piriform fossa and all. Results, control rate 70 to 90%. Coming to the procedures for transglottic cancers. So now we are left with few more things to discuss. We'll discuss in part 2. So we'll discuss the from here procedures for transglottic cancers. We'll discuss in the part 2 of the video now.
Okay.